Thank you very much, Professor Abdullah, for the invite, and I would like to thank the committee as well. So maybe just one important comment on the guidelines and the changes of the guidelines. Now it's part actually of the guidelines to try and get patients in sinus rhythm so that you can evaluate their, the impact on their quality of life. So, okay. My outline is going to be a quick introduction, important concept in atrial fibrillation, rhythm control and the evidence for it, then why ablate, available strategies, and take-home messages. Of course, we all know atrial fibrillation is a supraventricular tachyarrhythmia characterized by uncoordinated atrial activation leading to atrial remodeling. And we class it as electrical remodeling that happens within days, then contractile remodeling, and then the structural remodeling, and the autonomic nervous system remodeling as well. It's the most common sustained cardiac rhythm disturbance in adults. And of course, we all know the impact of the hemodynamic impairment related to thromboembolic events of with atrial fibrillation. So I always like to show this slide in any talk regarding atrial fibrillation. And it actually makes sense why we need to see these patients early rather than late. So we need to see them in the paroxysmal stage where the main driver or the main cause for atrial fibrillation is still remaining in the ectopic focus in the pulmonary veins. So you can imagine, and it actually has been shown more and more in recent studies, that the sooner you impact these patients, the better the long-term result. You can even in some cases eliminate the atrial fibrillation completely in these patients. So the sooner we get them in the green stage where it's still paroxysmal, the better long-term result for these patients. So I think one of the most important papers that was published recently is the ESAF-NET4, which actually managed to demonstrate for the first time an impact on the mortality and the hardcore outcomes. It did actually show a benefit for rhythm control in atrial fibrillation patients. Of course, we all talk still about the AFFIRM trial where the rate and rhythm control did not really impact the outcome, hardcore outcome for patients, but there were key differences between ESAF-NET, and we'll talk about them. So as I mentioned, it actually showed a significant reduction in primary endpoints like cardiovascular death and stroke, which was a bit different than the Cabana, but this study in particular was, in my opinion, positive for the initial start that we talk about. These were early rhythm control patients, meaning the rhythm control strategy was done within a year of diagnosis of atrial fibrillation. Number two, the mode of rhythm control. By now, I think we have more and more evidence in so many studies that atrial fibrillation is better controlled by ablation rather than by medications. The long-term result has been shown in so many studies, and we show some of them right now. And most of the patients actually remained in normal sinus rhythm in the intervention arm, unlike, if we recall, the AFFIRM trial, where most patients were actually in atrial fibrillation by that time the analysis was done. But because it was an intention to treat paper, it did not show the benefit. But it made sense because most patients were actually in atrial fibrillation by the time of analysis. So why ablate? As I mentioned earlier, now we have, I would say, at least 7 different studies are showing the exact same Kaplan-Meier curves. And it has been shown regardless of the ablation technique, whether you go for radiofrequency, for cryo, and more recently with pulse field ablation, it's always shown a significant difference between patients who underwent ablation and patients who were treated by medical therapy. So as we mentioned, the Cabana trial, again, showed the same Kaplan-Meier curve where ablation was superior to drug therapy in maintaining patients in sinus rhythm. Of course, the Cabana did not show a huge difference in the mortality and the cardiovascular death when they did the analysis. However, we did benefit from the study in showing the subgroup analysis. So people who did well with ablation were actually younger patients. A subgroup of the Cabana was the Cabana heart failure. It did show a significant difference in people who have heart failure. So ablation did well for patients, reduced their mortality, reduced the recurrence, and reduced their admission for hospitalization when we're talking about heart failure patients. So because it was a 10-minute talk, I didn't get the time to talk about all the studies that were published recently. However, if we try and summarize the clinical trials regarding atrial fibrillation ablation, we know they improve the clinical outcome. We know they improve heart failure and left ventricular ejection fraction. It actually lowers mortality. The targets for a first intervention is primarily pulmonary vein isolation. We can talk about other techniques as well. It improves the quality of life. It reduces or eliminates, in some cases, the recurrences of atrial fibrillation, definitely reduces the AFib burden. And we have three main technologies if we exclude the surgical technique. So we have radiofrequency, cryo, and pulse field ablation. And if we see the lower part of the slide, the benefit is higher when you have patients who are highly symptomatic, lower quality of life, and patients who have heart failure. So as we just saw, how did this translate in the guidelines? We have a class 1 indication when you have a patient who have paroxysmal atrial fibrillation to go for atrial fibrillation ablation as a first-line therapy. We have a class 2B when it's actually a persistent atrial fibrillation, but again, it would go to a class 1 of the patients actually failing atrial fibrillation, like if we chose rhythm control and the patient's failing medical therapy. Of course, for patients with heart failure, it was already there before. It's a class 1 recommendation to take these patients for ablation. I won't talk about the medical therapy. Again, we see on the paroxysmal atrial fibrillation part, it's a class 1 to go directly for atrial fibrillation ablation. And when it's persistent atrial fibrillation, it's a class 2B. But all of them, if you fail with medical therapy, it's a class 1 indication to go for atrial fibrillation ablation. So what are the available techniques for atrial fibrillation ablation? We call it fire, ice, or pulse field ablation. So the main difference, and I think the most recent tool that we acquired for atrial fibrillation ablation is the pulse field. And as you can see on the graph, pulse field ablation is a non-thermal ablation technique for these patients. So you avoid any collateral damage that is done on organs other than the targeted myocytes. Unfortunately, like with the radiofrequency, even with cryo, we did see some damage to the adjacent organs just because of the thermal impact of the ablation technique itself. However, with the pulse field, we have eliminated this risk completely. They tried even supratherapeutic doses of the pulse field ablation in some patients, and studies were done to see if there was any esophageal damage. There was none. Any nerve damage, and there was none. So, like as an electrophysiologist, who I would like to see referred for atrial fibrillation ablation, ideally younger patients, and this was what Cabana has shown. Younger patients, they benefit more. Paroxysmal atrial fibrillation, especially if they have tachycardia-induced cardiomyopathy. Controlled risk factor, and this is a very important thing that we need to start targeting in patients who have atrial fibrillation. We need to target the risk factor that actually initiate or put these patients in risk and suffering from atrial fibrillation. Patients who failed or didn't tolerate at least one antiarrhythmic, not a very dilated atrial fibrillation. So my take-home messages: atrial fibrillation is a multifactorial disease in which controlling risk factor is cardinal. Rhythm control has more and more evidence for superiority to rate control. Catheter ablation is superior to antiarrhythmic drugs for maintaining normal sinus rhythm. early referral is a key, and it's linked to a better long-term result. And I quote Dr. Luigi De Biasi, when you have AFib, intervene early, and intervene early with ablation rather than medications. Thank you very much.